Hey, good morning, and thank you for attending our Grant Ross lecture. My name is Xiaobo, one of the second-year cardiology fellow. I'm pleased to introduce to you our speaker, Dr. Snyder. Dr. Snyder graduated from Medical School of Wayne State University in 1993. He finished his pediatric residency and cardiology fellowship in Texas Children's Hospital, pediatric electrophysiology in Baylor College of Medicine in 2000. Dr. Snyder used to be a director in Yale University School of Medicine Ochsner Clinic in Pediatric Electrophysiology, Chief Division of Pediatric Cardiology of Case Western Reserve University School of Medicine. He then joined VCU School of Medicine in 2022 and serves as Tenured Professor of Pediatric and Chief Division of Pediatric Cardiology. We are grateful for Dr. Snyder's expertise on this topic and look forward to learning from him. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and the end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Liston. I will now turn it over to Dr. Snyder.
Good morning, everyone. I think Shannon has a couple of slides that she wants to share with everybody.
I already shared them and then I stopped sharing, so you can go ahead with yours.
Okay.
Snyder.
All right.
Thank
So
you.
let me share my screen and we can get started. So this one. Okay. Good morning, everyone. And I'd like to thank all of y'all for inviting me to give adult cardiology grand rounds. This is a great treat for me as a pediatric cardiologist and electrophysiologist to be able to talk to y'all about something that I do and love.
Said y'all.
So I've decided to talk on a subject that is very near and dear to my heart, and it's really about teamwork and collaboration and the ties these into patient care through convergent thinking in the diagnosis and treatment of fetal dysrhythmias. I know many of you are shaking your heads right now and wondering what aspects of treating a fetus you are involved in. But I hope at the end it will be clear that an adult cardiologist, adult sonographers, and adult cardiac nurses are a very important part of this team. So my objectives for this talk are to define teamwork, as well as the team needed to treat this common occurrence, and then also to define the amount of collaboration required, which is a lot. We're also going to discuss divergent goals of the team. When you're talking to an OB, their goals are maternal health and a live baby. When you're talking to the NICU and a pediatric cardiologist, you're talking about a live, healthy baby. And our question is, there's a mother involved? And when you're talking to an adult cardiologist, they're saying, why are you giving a healthy woman toxic medications to treat something? So, and then we're going to talk about convergent thinking. Everyone on the team will understand the goals, healthy mom, and the birth of a healthy baby. This is really important when we're talking about these kind of things and these patients in snap decision making when a baby, a fetus comes in and the mother is distressed and the fetus is severely distressed. Everybody has to be on the same page. And we're also going to talk a little bit about diagnosis and treatment of fetal arrhythmias, a little bit about the who, a little bit about the what, a little bit about the when, and a little bit about the where and the why. But most of the talk is going to be about the team. And the most important message that I have is the patient is always our primary focus. If we remember this, this makes it so much easier for all of us to come together as one team. I also need to describe a word that I'm going to use a couple of times, and it's dyad. In this case, It's really consists of two parts. This is a medical situation. In this medical situation, the dyad is the mother and the fetus. And this is a very unique situation in medicine where we treat a healthy individual with toxic medications, and this affects the outcome of another quote unquote patient. We have to give the mom medicine to treat the fetus that's in tachycardia. And as an Ohio State fan, it is really hard for me to show this slide, but the mantra that is talked about in this is very important. And I'm going to read this famous quote from Bo Schembechler. No man is more important than the team. No coach is more important than the team. The team, the team, the team. And that's really what's important with this is all of us, adult cardiologists, pediatric cardiologists, pediatric EPs, adult EPs, neonatologists, maternal fetal medicine doctors, and OBs are a team in this, and we're caring for a fetus and not necessarily a mother. So we're going to define teamwork, and define the definition of teamwork as I see it, and for this talk, is a combined action of a group or people, especially when, and I love this, effective and efficient. And this is what this team really needs to do, because mothers will oftentimes present into a maternal fetal medicine doctor or their OB discussing how their baby is not moving. When the OB does a brief ultrasound, they'll see tachycardia. They'll send them to a maternal fetal medicine doctor, which takes hours. The maternal fetal medicine doctor will do a scan, send them to a pediatric cardiologist. You're talking about a half a day's time before we even come up with a true diagnosis. And so it really needs to be efficient and effective. And then this relates to the cohesiveness of the team. And to maintain that, we really need to create a positive working environment. And I've seen it here in the two patients that I've been part of this team, is it works really well. We teach, we communicate, okay? And then we recognize the strength and skills of each team member. And this is really important when you have a mom who is in OB, their understanding of fetal arrhythmias is less than mine, and we go down there and we teach the parents, we teach the nursing staff, we teach the OB interns that giving mother medicine doesn't necessarily cure this within 5 minutes like it would if we were treating mother's tachycardia. And this team is a unique situation, and it has a lot of people, starting with the mother-fetus dyad. Right? That's really the most important. If we make the patient and the fetus the center, you cannot go wrong. Then the mother's doctor, which includes OBs and maternal fetal medicine doctors. And then the neonatologists are always involved whenever it involves a fetus, because they want to make sure that that baby, and they're the experts, baby comes out happy, healthy, or they're planned to intubate this child, give them steroids, put them on ECMO. The neonatologists are very involved in this. And then the pediatric echocardiographer or fetal doctor. And then we also need a pediatric electrophysiologist, because sometimes these tachycardias are so difficult that it's really wonderful to have a pediatric EP like myself or Dr. Phillips involved in these cases. When we're involved, we're thinking solely about the baby. Then really to be clear and to monitor the mother and to make sure that the mother is safe, we rely on the adult cardiologists, echocardiographers, and adult EP doctors. We put these mothers on extremely toxic medications that we don't know how their bodies react with this when they're pregnant to treat the fetus. And so we really need y'all to be on board and to be helpful and to be collaborative in this case. And then this doesn't even, we're not even talking about the The nursing and the family is always involved. And then all of this entire team is really there to care for one patient. And it's really two patients, but it's one patient. So I put this in here because communication is really key in this. I have to be able to talk to the OBs, the neonatologists, the adult cardiologists, and we all have to set expectations of what each other's lane is. And so I love this, cartoon here. And so now we have this unique multidisciplinary team, OB and adult cardiology to care for the mother, pediatric cardiology and neonatologists to care for the fetus, and support staff of nurses caring for the mother, nurses caring for the fetus and the newborn, social workers, sonographers, just to name a few. And what do we need to ensure success of the entire team? Because each of the team have divergent thinking. Well, we need open communication. Each expert, be it the OB, the neonatologist, pediatric cardiologist, or adult cardiologist, need to verbalize their assent and concerns with regard to whatever the whole team decides. If we're going to start this mother on Nadolol or atenolol or amiodarone, we really need the adult cardiology team and the OBs to weigh in on that. We need the neonatologist to weigh in. They all need to work together. They need to collaborate to care for this dyad, knowing what they know and admitting what they don't. And they also need to practice active listening, which is one of my tools that I'm learning to do much better job at. What effect is this medicine going to have on the mother or her fetus? What kind of monitoring do they both require? Can or does the patient need to stay in the hospital? And oftentimes these babies come in and they don't need to stay in the hospital much more than 6 or 8 hours, and sometimes they need to be here until delivery. With open communication and active listening, the team and the family, we develop a treatment plan for the patients, patient or fetus that is driving both by data and expertise. This slide really, I put this one in here to illustrate communication. Good communication has positive impact even when the news is bad. And poor communication can have a negative impact even when the news is good. And this communication must be delivered by the team or a representative of the team to the mother and oftentimes to her spouse or significant other. And last but not least, after identifying the dyad, gathering the necessary team members of OB, pediatric cardiology, adult cardiology, nursing, social work, communication has begun. We step into collaboration. This is similar to teamwork in that it is a product of 2 or more parties working willingly together. And I love that, willingly. Oftentimes we are put into a position where we are asked or forced into doing something in emergent situations that we are uncomfortable doing. And this is really, collaboration is having willing people involved in this. Medical collaborations, as we all know, have proven over and over and over again to improve patient outcomes. I've seen it with my own 2 eyes when we've had a team that treats this, the patients, the communication with them, they all get a whole lot better. Whether the patient comes out and requires ECMO or the patient we're able to terminate the tachycardia. Having an entire team improves their outcomes. It also improves their quality and their safety. I don't look at the mother as a patient when I'm treating these. I'm looking at the fetus as the patient. I think of the mother, but I don't know what the volume of distribution of these medicines are. I'm not asking the mom if she's having lightheadedness and dizziness or paresthesias or anything, because I'm focusing on the fetus. It also helps disciplines work together. We all need to work together. We all need to do more collaboration across adult and pediatric medicine, because now patients are living much longer lives, and adult congenital heart disease is really the first and the classic example of this, where they're surviving into adulthood, and we need people like Sangeeta helping us care for these patients. And then it also expands access to care for these patients. Now that we have the team, they are communicating and they are collaborating, we need to think about how each team member thinks. Are they divergently thinking, which is great at generating multiple ways to solve a problem. But this takes time. This is how they made the Apple computer, is they had a bunch of people in a garage divergently thinking about ways to make a computer and make it look nice so that people would buy it. Or is the team coming together around this unique dyad, driven by existing data, rapidly doing their part so that the mother and fetus get the best care in the most rapid time possible, or convergent thinking? So a divergent opinion is one that does not match your perspective or differs from the majority. It is an opinion that goes against commonly accepted belief or view, but these are how major issues and problems in the world are solved. Divergent thinking is extremely creative thought process that involves generating multiple ideas and solutions to a problem. Divergent thinking can lead to analysis paralysis. You get 10 people in a room and you say, solve the problem of how far the DDEC is from the main hospital. You're going to have 10 different ideas. All of them are going to be good. And we're going to be sitting around in 5 days still trying to discuss what the issues are. This can lead to paralysis. This is wonderful for many things, but this is not the way to treat a maternal fetal dyad when minutes and hours can make the difference. And here's an example of divergent thinking. And again, it's the mother and fetus, and the fetus is in tachycardia, and you have all these fantastic opinions. We have some divergent thinking even within our division. I love amiodarone. My partner, John Phillips, loves sotalol. I've had a patient have a couple of problems with sotalol. He's had a couple of patients have problems with amiodarone. But when it comes to this kind of issue, we have to be convergent and follow the data. Convergent opinions are ones that become more similar or come together. Convergent thinking focuses on finding a single, well-defined solution to a problem by integrating expertise, which OB is, sorry, 1 second, my computer is going to shut down. Integrating expertise for team members to form comprehensive treatment plans for specific diagnosis. This allows for rapid mobilization of the entire team in a manner that is borne out by science and expertise. Now we're going to shift gears and we're going to go back to the team. And the team is really massive in this, right? The team really requires the dyad or the patient, the family, nursing, OBs, maternal fetal medicine, neonatology, 2 pediatric cardiologists at a bare minimum, and sometimes 3, and 2 adult cardiologists. So the general steps to success in treatment of fetal tachycardia after the team is assembled and waiting is recognizing that the dyad is at risk, the mother, baby, And it's usually the fetus or the baby that is really at risk, oftentimes in this. Then it's identifying the tachycardia. Then it's the selection of medicines. And the thing that we don't think about in pediatric cardiology is when we give a medicine to this dyad, the mother gets the medicine. Or we can give it directly to the fetus, but the mother still sees the medicine. So we have to think of a selection of medicine that's safe for both. Then we have to assess the safety for both the mother and the fetus. And then we have to think of ways to monitor both. It's very easy to monitor a mother. It is very difficult to monitor a fetus, especially outpatient or even inpatient. There's really no phenomenal way of monitoring the fetal heart rate. Very few ways to get a fetal electrocardiogram, especially if the fetus is in their 20-week gestational range. So in our steps to success, really, we're going to talk about how a fetus comes to all of our team's table. And really the first step involves the obstetrician. The obstetricians are the front line. They are the patient, the mother's doctor. Mothers will come in and complain to the obstetricians about the baby not moving so much, or mother's intuition, and mother's intuition is always right in these cases. And it's also just found sometimes fortuitously. These are found when the obstetricians are doing the biophysical profiles on the patient, and they usually do them around 16 to 20 weeks. Sometimes 22 weeks. It's a screening ultrasound where they determine the baby's age and their due date. They evaluate for growth and movement. They evaluate the heart rate. They assess the amount of amniotic fluid. They detect issues with organs and muscles and bones. They detect the baby's sex. And then they also do a routine screen of the heart with cardiac structure, function, and at least an eyeball determination of the rhythm. When they detect issues at an obstetrician's office, their role is to send it to a perinatologist or a maternal fetal medicine doctor. The maternal fetal medicine doctors, Dr. Ramos and his team, then they do a further assessment of the dyad, the mother and the fetus. They assess maternal health and risk factors, and then they ultimately perform a fetal scan, very similar to the biophysical profile, but a little more in depth. And they do what we would consider a routine assessment of cardiac structure and function, a little more in depth ultrasound of the heart, where they assess the 4 chambers and the 4 valves. And really their main deal is that they assess for any form of fetal compromise. If they detect any issues with the heart, they send it to a fetal cardiologist. The fetal cardiologist beats the drum again. They talk to the mother. They assess the fetus. We do what we would consider a complete fetal echocardiogram. These are really amazing things that were started just a couple of years before I started my fellowship, and have progressed to now they can see almost everything. The fetal echo they do is really to assess the heart rate and rhythm and look for structural malformations, and they also check for fetal cardiac compromise. A fetal arrhythmia, we're going to switch a little and talk about fetal arrhythmias. The fetal arrhythmia is really best defined by an irregularity in the fetal cardiac rhythm, or a regular rhythm that remains outside the range of normal. By the American College of Obstetrics and Gynecology, they talk about mild tachycardia in a fetus of a heart rate between 161 and 180, and severe tachycardia greater than 180. Davignon, who is an old cardiologist from Montreal, Canada, defined in a baby that Normal heart rates really fall between 88 and 160. So this is one of the areas that we have some divergent systems and divergent thinking. Fetal dysrhythmias, or irregular, too fast, and too slow rhythms, are identified in 2% of all pregnancies. That's a lot, but result in 20% of fetal cardiac referrals. 20%. These numbers significantly underestimate the burden of disease. So approximately 10% of these tachycardias result in fetal demise, high drops, or premature delivery. And premature delivery is very commonly a major issue in kids, depending on when they're premature. We had a premature delivery about a month and a half ago for fetal tachycardia, and the kid was 37 weeks, and the kid wound up going on ECMO. So it results in apnea, temperature instability, nutritional deficiencies, necrotizing enterocolitis, and all kinds of long-term school and lung issues. So this is an old paper that I love to quote. Charlie Kleinman was a pediatric cardiologist, and Josh Gopal was a maternal fetal medicine doctor at Yale. And they studied all of the fetal dysrhythmias that they saw at Yale over a 10-year period. And they had 1,384 of them. And as you can see from this, the vast majority of this just were single extra beats or extra systoles, either atrial or ventricular in nature. But then they found supraventricular tachycardia in 69. They found atrial flutter, which is common in a newborn, common in a fetus, relatively uncommon in a newborn or in a child. So that really accounted for 80 of the arrhythmias. They found AV block in about 50 of them, VT in 7, AFib in 4, atrial tach in 4, and then junctional tachycardia in 2. So now we're going to switch. And the real question is, why do we treat these dysrhythmias? Antiarrhythmics are dangerous. They're all pro-arrhythmics. And we are asking a healthy mother to take these medications. We don't know the pharmacokinetics in a pregnant woman, let alone those of a fetus. We have little idea how much passes through a normal placenta, let alone one that is stressed, which often occurs in fetuses with tachycardia. Their toxicity, the side effects to the mother and fetus, and they also may not be effective. So we really have no idea if these are going to spontaneously resolve. Oftentimes, we see a patient one time and they're having PACs or PVCs or something like that, and they resolve. And then there's always the age-old, just deliver and treat the fetus. This is what happened 30, 35, 40 years ago. Any fetus that was in tachycardia, we would just deliver the fetus and treat them as a baby and not treat the mother. So fetal arrhythmias have a really high morbidity and mortality. It's rare that we see mortality, but it's rare in the world of pediatric cardiology that we see mortality. But morbidity is very large in these patients. Oftentimes, these patients develop myocardial dysfunction, the fetuses do. Congestive heart failure. Another word for myocardial dysfunction and congestive heart failure is something we call hydrops. And when these maternal fetal transfer of medicines can be compromised due to swelling of placenta when they have hydrops. and this can result in fetal death. Fetal demise increases proportionally with the degree of prematurity. I have seen a 16-week fetus with SVT and high drops. I remember sitting in the room telling that mother there was very little chance of that fetus surviving. At 16 weeks, there's not anything that we can do. The patient is too small to deliver. We started the mother on amiodarone. The obstetricians, and this was at another institution, wouldn't even admit her to their service. So we had adult cardiology admit the healthy mother to their service while we gave her amiodarone. And eventually it broke the tachycardia. The high drops resolved, and at term, a normal baby was born. But the earlier a baby is delivered results in really, really bad things because their lungs are not mature. Many of the medicines that we use, beta blockers, can affect their lungs. We're using propranolol. That can be bad combination when you have premature lung disease. Babies are feeding sometimes and not feeding sometimes when they're really premature. And so these can be really difficult tachycardias to control once they're born. And then the other issue is it's really difficult to determine who and what patients are going to develop high drops. So these are all factors that influence teams' decision-making. The type of arrhythmia, is it slow atrial ectopic tachycardia that is intermittent, or is it AV node-dependent reentrant tachycardia with a heart rate of 260 that is incessant? Frequency and duration, is it consistent? Is it consistent, we believe, is worse than intermittent, but there's little way to know just how frequently the fetus is in tachycardia because there's no real way to monitor these patients. As soon as the probe or the ultrasound is completed, the mother wipes off her abdomen and leaves. And we don't know if the patient who was not in tachycardia or was intermittently went into it as soon as she got up. Gestational age, again, the more premature, the worse the delivery. And is high drops present? Again, this is fetal congestive heart failure. When high drops is identified, this elevates the need to rapidly treat and or deliver the patient. And then is structural heart disease present? Many think that the presence of structural heart disease makes the tachycardia worse. But delivery of a premature infant with congestive heart failure is fraught with all the aforementioned complications. So I love this book, Heart Failure Made Incredibly Easy. I put heart failure in a fetus is made incredibly easy. We're going to talk just for a minute about what high drops is because you guys don't see this. But high drops is really excess fetal water. And the water is really everywhere. They have ascites, they develop pleural effusions, pericardial effusions, edema of their skin, AV valve regurgitation, and diminished fetal movement. Now, a lot of people have studied high drops in the world of pediatric cardiology and in obstetrics. One study showed that the incidence of high drops, developing high drops, was increased when ventricular rates were greater than 230 beats a minute. Sounds pretty reasonable. Another study, a little larger, showed there was no correlation between ventricular rate or mechanism of tachycardia and developing high drops. So that's out. Another study showed that sustained tachycardia greater than 12 hours and a lower gestational age of presentation. So if the fetus comes in at 33 weeks and has been in tachycardia for greater than 12 hours, they have a higher incidence of high drops. But then another study, again, larger, showed that neither duration or the rate predict high drops. So we don't really know what we don't really know. We do know that high drops is present in about 43% of fetuses with consistent tachycardia. Control of the tachycardia is much more difficult in a hydropic infant. And then hydrops requires more medicines, 2 versus 1 to get control. And it also requires more days. You see this. Most fetal tachycardias that come in require 1 medicine delivered to the mother, and within 3 days, the fetus is out of tachycardia. If they're in hydrops, it takes 2 medicines and up to 12 and a half days to get a patient who is in severe congestive heart failure out of tachycardia. This is a quick fetal ultrasound of a patient, and you can see from this that the patient's heart is beating super fast. This is a patient in SVT, and you see the areas of the pleural effusion, pericardial effusion. So this is a fetus that's in hydrops. And then you also, another thing that you may or may not notice is the fetus isn't moving. This is a fetus that's really in dire consequences currently in tachycardia with hydrops. And this is another one of my favorite expressions is the more you know you don't know. And this is really important in fetal tachycardias is we don't really know everything about them. So this is just an example of how we manage fetal tachycardias. So when a fetus comes to a pediatric cardiologist or a fetal cardiologist, they do a complete fetal echo to determine the complete structure. Does the patient have transposition? Do they have tricuspid atresia? Do they have total anomalous pulmonary veins? They do all that. They make sure that the cardiac function and rhythm of the heart are normal or abnormal. If they detect an arrhythmia, they do an M-mode image, which we have illustrated here. And the M-mode image puts a cursor through the atrium and the ventricle, which this illustrates, through the walls, and then they record the M-mode. Or they do it through the aortic and atrial walls. They record the tracing, and then what we do is we construct a ladder diagram. And ladder diagrams are old school ways of figuring out where, and from this illustration, you see every A goes to every V. This patient is in sinus rhythm. This is an example of a patient in atrial flutter. You see here, all on the bottom, the atrium, all those little contractions there are atrial. And you see the top, the ventricular beats are much slower. The ladder diagram illustrates atrial flutter. This is a patient that, if you did a ladder diagram, might look like atrial flutter. But another important thing is you need to understand the speed of the tracing, just like EKGs. This is a very slow tracing. And so what you see is you see lots of atrial contractions, few ventricular contractions. But if you look at the top, the atrial rate is just under 100, and the ventricular rate is just under 50. This is a patient with congenital complete atrioventricular block. Again, another example of really this super fast episodes of tachycardia that we're seeing in these patients. So this brings us to the big question. When do we treat a fetus in tachycardia? Do we keep the bun in the oven? Do we deliver them emergently? Do we treat the mom with antiarrhythmics? Do we treat the fetus directly through the umbilical artery and umbilical vein? There's a lot of options that we have. Prior to any decision making regarding fetal tachycardias, in my opinion, we need to assemble the entire team. The OB, maternal fetal medicine, and fetal cardiologists are the ones that will help determine whether the patient is in bad tachycardia, high drops, and how worried they are. get a fetal biophysical profile by the maternal fetal medicine doctors or the OBs. Is the fetus viable, moving? Are they okay or not? If not, then delivery often occurs emergently. The fetal echocardiogram performed by the fetal cardiologist helps determine the rhythm, high drops, cardiac function. Once those have been completed and there's a determination that we need to treat the mother, this is where adult cardiology's expertise is so needed in this. At this point, up to this point, the patient has seen two, maybe one, maybe two fetal or pediatric cardiologists. Our focus is solely on the fetus, and we need y'all's help when we decide to dispense medicines to the mother. We need to make sure that the mother has an EKG. The mother's history doesn't show any worries that would make you, adult cardiologists, change the medicine that we use. We also oftentimes need a maternal echocardiogram, and these things need to be done quickly. We hospitalize these patients that we're worried about, and the entire team really needs to come together, make their decisions, and then everybody needs to listen to the family and to each other and focus on this dyad. This is where convergent thinking is really important. Fetal tachycardias do not occur infrequently, but the team have to understand how to work up on the mother and the fetus, make sure it is done rapidly, successfully, to ensure safety and outcome for both. There are a number of treatment issues. First and foremost, our knowledge of antiarrhythmics in pregnant women is somewhat limited. And I say somewhat limited in quotations because it's more than somewhat limited. We don't really know. No one wants to study the pharmacodynamics in pregnancy of a toxic medication by through the FDA. The pharmacology of this, it will and oftentimes remains unknown. And then the treatment is based on risk and benefit ratio. The mechanism action of the tachycardia, the mechanism of action of the medicine, is it going to affect the mom? Maybe, maybe not. Is it going to affect the fetus? For sure it is. How safe is this medicine during pregnancy to the mother and then also to the fetus? We as pediatric cardiologists, again, are focusing 99% of our thought process on the fetus, and we need your help. And then the risk of treatment. The risk of treatment to the mother is it's going to cause a lung issue, a liver issue, prolong her QT. And what is the risk of not treating in the fetus? Are they going to develop high drops? And the use of drugs in pregnancy requires special attention to the pharmacodynamics and the placenta, something that until very recently, nobody has truly focused on this. So now we're at that unique phase where we need to do a balancing act. Is it more harm or is it better to keep the patient in? Is it better for the mother and the fetus? As we all know, most mothers would give their lives to have a normal baby born. But we can't, we as physicians have to step in sometimes and talk the mothers through this difficult decision. Is it better to deliver? Is it better to treat through the mother? And the vast majority of mothers, again, would do anything for their fetuses. So over time, a number of teams have developed their own algorithms. These algorithms have stepwise walkthroughs from the diagnosis of fetal tachycardia. Do they have high drops? Do they not have high drops? Do we start digoxin or flecainide? Does the SVT continue? If it does, then what do we add? Sotalol or amiodarone or whatever. Okay. The diagnosis okay, of this arrhythmia is there's no real algorithm in here, and these are made by pediatric cardiologists for early delivery. None of these call for early delivery at any time. We believe that treating the fetus while they're still on their ECMO machine inside is most of the time is better. But these are pediatric cardiology viewpoints. They're not OB viewpoints. They're not maternal fetal medicine viewpoints. We're not focusing on giving the mother these toxic medications. Our goal is a term healthy baby. But there does need to be bandwidth in the really sick fetus near term with cardiac dysfunction and high drops. This paper was recently put out by Heart Rhythm Society and had OBs, pediatric, and adult cardiologists working on it. This algorithm is similar to all the others with the medications, but this one calls for aggressive management in the fetus with tachycardia. In this one, it actually calls for direct injection into the fetus of the digoxin. I've used amiodarone directly given into the fetal umbilical vein. You can actually give adenosine into patients, okay? And then this one actually calls for close to term delivery of the fetus with high drops. This, I think, is probably the most up-to-date algorithm that uses the team to come up with this algorithm. So why is it important that we have adult cardiology on this team? We, the rest of the team, are asking to give toxins that we don't really have a great idea how the pregnant body is going to react to an otherwise healthy person. We need adult cardiology to give us their opinion. To me, as an electrophysiologist, if you came to me and said, I'm going to give this 16-year-old girl flecainide because I just want to give her flecainide or amiodarone or sotalol or ibutylide, I would have a lot of questions for you. This is where we need adult cardiology. We need adult cardiology to come and understand why we're giving this, which they do, but then also really weigh in on the issues from the maternal perspective. We need to have somebody help monitor for these side effects. We need somebody that can give at least a guess of how the maternal circulating volumes are going to affect the metabolism of these medicines. Does it increase maternal renal clearance of these? And what do we do when there's placental edema? We also need some help with dosing of these medications. They're often written about in pediatric cardiology literature and in the OB literature, and most of the OB literature about dosing of these medicines is written by pediatric cardiologists. So the medication doses often affect the risk for the patient, the mother, the risk for the fetus, and we need y'all's help in really assessing and mitigating and monitoring for maternal toxicity. We have a protocol where we admit these mothers to the OB unit, but on the OB unit, it's really hard to measure or to put the mother on telemetry. And then how do we monitor the fetus? Luckily, with regard to safety of medications given to pregnant women, there's been a major focus on the safety to the fetus, but in the past, not necessarily to the mother. But recently, the FDA has changed how medications are labeled during pregnancy. They used to be labeled as A, B, C, and X. And C's were ones that were felt to be not safe. X's were ones that nobody really had studied before. It was a disaster because you would go in and look at a medicine that you have used yourself on tons of women and it would be labeled as an X. And then 2 weeks later, it would be a C. The FDA has recently changed this to really now just labeling them as safe, use caution, or risk, as you can see here. As for doses, I have a few examples here of the massive doses. These are massive doses for a pediatric electrophysiologist. I grew up using digoxin to treat fetal arrhythmias, and the doses of 1.5 to 2 milligrams over 24 hours is a massive dose for a pediatric electrophysiologist to give to his patients, especially when we're focusing on the fetus. These loading doses can be toxic, but for some reason, pregnant women eat up digoxin and laugh. When we send a mother home on digoxin, they come back and they get a dig level done, and their dig levels are nowhere near toxic. So we really don't really know much about how mothers' bodies metabolize a lot of these medications. This is an example of amiodarone use in pregnancy. These are all written up through that Heart Rhythm Society paper. But again, I use a lot of amiodarone. But when I'm in the room with the mother who is starting amiodarone, I can tell you I've never asked the mother if things that she's eating taste like metal, or if the mother is having any issues or problems with the amiodarone. I'm focusing solely on the fetus. The question we have is, and we really need adult cardiology in this, is how long do we have to monitor the mothers for? When we see these patients, we monitor the fetus. I tend to help with directing how long the mothers are monitored for based on what I do for a baby or a newborn or a young kid. Do they need echoes before they start their antiarrhythmics? They do for flecainide. We tend not to do flecainide or echoes for flecainide in pediatric patients because we rarely have congestive heart failure in pediatric patients. Pediatric, not fetal patients. Okay. How often do we need EKGs on these patients? We're using pediatric data to look at adult data. Do we need to follow levels? And then what if we get a side effect? We really need the adult cardiologist to help us, right? We do the best that we can to ask, are they nauseous? Are they seeing bright lights? Are they doing things like that? But chest pain, liver issues, abnormal EKGs, and I wouldn't even know how to interpret an EKG in a pregnant woman, let alone an abnormal EKG. Thankfully, you can see from this study, the number of side effects to the mother, at least the ones that are reported, because we know they're all superhuman, is relatively low. Most of the side effects are noted in two medicines, DIG and flecainide. Now, those are really the two most common medicines that we use, but those are ones that are relatively low. And then what I found really interesting about this study is they showed a combination medicines, right, where they used DIG and flecainide, and it had a 12.5%, but other combinations had very low side effects. Other aspects of maternal follow-up for fetal SVT include really after the team directly monitors the mother, which is easy. We can put mom on telemetry. We can do an EKG on mom. We can do a blood pressure on mom. We can ask mom if she's sick to her stomach. We can ask mom if she can see bright lights around. We can tell the mom of all these things. But there's no way to monitor a fetus. While the mother and fetus are inpatient, we can use cardiotocography, which is here, but this doesn't measure the EKG. This doesn't measure the fetal QT interval. This doesn't measure their AV block. This doesn't measure any of that. It just really measures their heart rate. That's it. This is pretty good in that we are able to assess changes in their heart rate, especially when they come in and their heart rate is originally 200, and then in the middle of the night it becomes 120. You know you've converted that fetus. Really doing fetal ECGs, there's one place in the country in Wisconsin at Children's of Wisconsin where they have a machine called the magnetocardiogram where they can do this. But it is not necessarily indicated to send a mother all the way up to Wisconsin to have her have this test done. So after the team decides the mother is safe and the fetal heart rate is safe or normal, in general, we bring the mothers back frequently, and sometimes it's 2 days later. Sometimes it's the next day. We have sent mothers home on a loading dose of digoxin and brought them back on Saturdays and on Sundays for fetal echoes, because that's really the best way for us to help determine if there's tachycardia. We also have the OBs do biophysical profiles on a much more frequent basis than they do. We often send the mothers home with a fetal Doppler monitors. These are very good, but one complication is if the child has or the fetus has complete heart block, the mothers can be monitoring their own heart rate, which can be picked up on this as opposed to the fetal heart rate. And then really the team relies on all members, the OBs, the maternal fetal medicines, the neonatologists, the peds and adult cardiologists, to get this unique dyad of patients across the finish line. Everybody's goal is delivering a healthy term baby without the moms experiencing any lasting or long-term side effects. Thank you. So really, in conclusion, it's all about teamwork and collaboration. This is the thing that, to me, is a piece of beauty. When you see it, you feel like the conductor of an orchestra when the OBs are calling the maternal fetal medicine doctors and they're calling the fetal doctors in pediatric cardiology, and they're having joint phone calls and they're talking to the patients. It's taking divergent teams, which these are, and focusing on convergent goals, collaboration, appropriate diagnosis. Really, oftentimes the hardest part is rapid team decision making. We have to figure out this fetus is in distress. Do we deliver emergently or not? Do we give the mom amiodarone? How do we give amiodarone? Do we give the fetus amiodarone? These are decisions that need to be done very quickly in a fetus that could be failing right before our eyes. And then it requires a lot of listening. My experience with adult cardiology has been fantastic. When we bring them by and they give their opinions about the mothers, and as a pediatric electrophysiologist, I'm enthralled because they're thinking of things very differently than I am when I'm thinking of the fetus. And then how do we treat them? And then what do we do with our reevaluations? Thank you very much for allowing me to do this unique presentation. I hope you all enjoyed it. And anyone has any questions, I'll stay on and hopefully answer them for y'all.
Thank you very much, Dr. Snyder, for this excellent and interesting topic. I don't see any topic in the chat. And as a adult cardiologist, I have very little knowledge about how to get in the EKG for those fetus. I am very curious that I just assume that it's impossible to get the surface EKG. I saw that you show a couple of slides with EKG correlating with echocardiogram. So I'm wondering, is that the rule that every time we have to get the echocardiogram, and how comparable and what are how consistency are those EKGs? Can we compare the previous EKG, especially when they develop hydrops?
So that's a great question, right? So there really currently in the world, there's really no way to do a fetal EKG. You can, as the baby is approaching term or at term, you can put a single lead on the head if the patient has ruptured, the mom has ruptured the membranes. Otherwise, there's no way to do it. So then it really requires doing a fetal echo. And our fetal echo docs are spectacular, right? They come in all hours of the day and night. They do this stuff. They are able to get the rhythm most of the time, right? Sometimes it can be hard to determine whether it's flutter or atrial ectopic tachycardia, or rapid flutter and reentrant SVT, but luckily we treat them pretty much the same way. But the issue is that an echo is a mechanical and an EKG is an electrical. And so junctional ectopic tachycardia is oftentimes diagnosed as VT because you see the V contracting and maybe the A is not. But that's a rare arrhythmia, and our fetal doctors do a spectacular job, and they are literally in all the time doing these things. So you're right, there really is no way to monitor. This is the conundrum, right? We can monitor the mom, but we can't really truly monitor the fetus other than with an ultrasound, and you can't tell their QT, you can't tell many other things.
Thank you.
Well, again, thank you all very much for giving me the pleasure of speaking at Adult Cardiology Grand Rounds. This is a thrill of a lifetime, and I hope to see you all around the next fetus with tachycardia. Would love to collaborate and communicate with all of y'all.
Good morning, Chris. This is Wendy Botner. I did have one question if you have a second.
Sure.
I really liked your emphasis on the multidisciplinary team and how important that is for these dyads. And one question I had was, you spoke quite a bit about the physicians and providers that are involved. I have to think, though, that there has to be a fairly high psychological burden to these mothers as well. And I just didn't know if you might speak a little bit to that aspect. Are, psychologists usually part of these teams, or how do we approach that?
That's a great question. And being married to a psychologist, right, she would say that they need to be involved. What we do is usually these are very rapid decisions, right? When a fetus comes in and they're in tachycardia, we're meeting with them, we're chatting, we're doing all those sort of things. And most pregnant women will, as you know, do anything for their fetus, right? And so we haven't had a psychologist, but when we're treating this mother and the mother is in the hospital, we've had social work come, but social work is not a psychologist. It's a phenomenal idea that we need the social worker and the psychologist, and really stressing the psychologist to come and help this mother. And really, it's not just the mom. I'm going to speak for dads too, right? Dads tend to be the ones that are sitting in the corner like a deer in headlights, and moms are very engaged in how this is going. And so, but that's a fantastic thought. And we'll definitely, Dilly is on, I saw him, and we'll get that taken care of for sure.
Thank you.